So good evening, everybody. We're going to get started. We have DA Ryan in traffic, the infamous traffic coming to Maynard from Boston. So she will arrive and seat herself as she comes in, but we'll begin with everyone else. I wanted to make quick introductions of our panelists. We have Senator Jen Flanagan making opening remarks. She is the Senate Chair of the Joint Committee on Mental Health and Substance Abuse, and also Corey Welford, Chief of Staff to Attorney General Maura Healey. Our panelists include Marion Ryan, as I said, Middlesex County DA, the Honorable Paula Carey, Chief Justice of the Massachusetts Trial Court, the Honorable Elizabeth Malia, State Rep and House Chair of the Joint Committee on Mental Health, Chief Mark Dubois, Maynard Police Department, Marcy Julian, Regional Manager for Learn to Cope, and Richard Albeg, Director of Emergency Services and ICU at Neshoba Valley Medical Center. Those are the folks on our panel. Good evening, everyone. I want to thank you all for being here. It is so important that we have these discussions on the state level, but it is so very important that we have it here on the local level. But I always am very appreciative of anyone attending these forums we are having and trying to have across the state on the opioid crisis. As you know, I'm Kate Hogan. I represent the town of Maynard, Bolton, Hudson, and Stowe, and I serve as the House Chair of the Joint Committee on Public Health. So I have been, over the last 6 or 7 months, being given a crash course on the opioid crisis, what needs to happen, prevention, and dealing with the crisis as a whole, both through legislation and out in the communities. I'd like to thank our distinguished public servants here tonight to add their voice and help educate our community on the opioid crisis. From 2000 to 2012, the number of unintentional fatal opioid overdoses in Massachusetts increased by 90%. Today, as we sit and stand here, 100 people per day die in the United States from an opioid overdose. What we have is a public health crisis. 4 out of 5 cases of heroin addiction start with prescription medications. So it is a crisis that has sort of been created through addiction to prescriptions. Many people start with prescriptions, and then it leads to the difficulty when you're addicted in acquiring them, which will move you quite quickly and more inexpensively to heroin, and that is what we have seen happen across communities in Massachusetts. And it requires our communities and our local state officials to work together to find solutions to this addiction crisis. Prescription drug abuse and the opioid addiction affects everyone. Before we begin, from our distinguished panelists, as I had said, I would like to welcome to the podium State Senator Jennifer Flanagan, Senate Chair of the Committee on Mental Health and Substance Abuse, and the Senate has also finished and presented a bill to the legislature regarding the next step in the opioid crisis. Please welcome Senator Flanagan.
Thank you, Representative Hogan, and thank you all for being here this evening. I think one of the most important aspects of the conversation that you're about to have this evening is community involvement. And I can tell you that my co-chair, Representative Liz Malia, who comes from Boston, is someone that I can work with time and time again to get things done. And I hope over the course of our panels talking, you really interject with some suggestions that you have from the community level, because I know a lot of times from the state and federal level, we deal with a lot of regulations and laws, but we need to see what's on the ground and on Main Street. As Representative Hogan said, my name is Senator Jen Flanagan, and I represent the town of Bolton, along with Representative Hogan. My roles on Beacon Hill, I'm the Senate Chair. I'm the Senate Chair of the Joint Committee on Mental Health and Substance Abuse with Representative Liz Malia. I'm the Senate Chair of the Joint Committee on Children's, Families, and Persons with Disabilities, so I have DCF and autism and welfare under those auspices. I'm the Vice Chair of the Committee on Public Health, so Representative Hogan is my chairman. And I also am the Senate Chair of the Senate Special Committee on Drug Abuse and Treatment Options. So I can tell you that most of my time is spent dealing with addiction and how addiction affects our communities. If you look at the month of September, my office was open 22 days. So you look Monday to Friday, 4 weeks out of the year. In the time of September, my office placed 14 people into detox. So when you think about the fact that, one, you're calling your senator when you have no place else to go for detox. Two, the senator's office now has to get involved in trying to find a bed and place you in detox. And three, you're trying to help a family who has become very much in crisis deal with their loved ones. That's not something you would expect from a Senate office. And that's why I think one of the most important things that I talk about time and time again is conversation. We need to change the conversation surrounding addiction. A heroin addict, and D.A. Ryan can attest to this, is not the person sitting behind a building next to the dumpster with a needle in their arm. An addict is someone that can be sitting in your living room. They could be sitting amongst us tonight. They could be our brothers, our sisters, our mothers and fathers, our aunts and uncles, and our cousins. And more importantly, they're walking around our communities each and every day searching for help. I know it's difficult to look at a loved one who has an addiction and want to try to help them, but have them fight that process. It's very daunting, it's very scary, and I know when we talk about we talk about having inpatient beds versus outpatient beds, or medicated assisted treatment versus complete abstinence, it really gets to the fact that each person is very unique in how they handle their recovery. And so what we're hoping that you have here tonight is a really frank conversation on what can be done and what you think is good for your communities. The truth of the matter is, the people sitting in the Worcester House of Correction or the Bill Ricca House of Correction or any of our sheriff's departments are coming back into our community. Whether they've detoxed or not, they're coming back into our communities. And this is not just an urban problem anymore. This is every single city and town that we have here in Massachusetts. And D.A. Ryan also has a great map of Middlesex County to show where the deaths are, to show where a lot of the usage is happening and where a lot of the activity is happening. But those of us on Beacon Hill are trying to get to the crux of this. So the bill that we passed last year into law, which Rep. Maya was a great help on, and Representative Hogan as well, mandated that insurance companies now have to pay up to 14 days of detox and post-detox treatment. That went into effect 33 days ago. So we're now seeing the fact that it's working, and we're hoping that we're taking literally a 4-lane highway and putting it into a 2-lane corridor, and hoping that these people don't come around and cycle through the system time and time again. The bills that you hear about now, the one that the governor has filed, the bill that the Senate has passed recently, and then hopefully the one that we're going to end up passing in the end, is about education and prevention. The one thing that we've actually learned about this is that there is not one way to fix addiction. We can't essentially fix addiction. We have to help the process through. So while last year we focused on treatment because of the number of deaths that we had in our communities, this year we're focusing on prevention and education. The one thing that I think of each and every day when I go to work and when I go home is that on this side I have people who are dying and that will die today and tomorrow. But on this side I have people that have yet to touch a drug who could be 7 and 8 years old that we need to prevent from becoming those addicts. The Academy of Pediatrics says that you should start talking to your children when they're 9 years old, because they know that Corona has a very nice ad during the summer that shows how much fun it is when you're at the beach and you're drinking a beer with a lime in it. They get that when people are smoking, that they seem cool and it's the fun thing to do. The kids are starting to understand what the commercials are telling them. And what we need to do is combat that with the facts. We're not saying you have to tell your 9-year-old everything. We can start by saying it's not good to take someone else's prescription out of their prescription bottle. We can start by saying there are good drugs versus bad drugs. But what we're saying is that you've got to get to them. And that's why when the controversial piece of my bill, the expert screening, went into the media, everybody thought I was urine testing every 7th and 10th grader in Massachusetts. The truth of the matter is SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. It's a 10-minute conversation with a kid to assess the risks that they have with alcohol and substance abuse use. It's an easy way for us to have a conversation to say, does this kid need help? Is he going down the wrong path? It's not to be intrusive, it's not to be judgmental, and in no way is the confidentiality going to be disclosed to anybody, even DPH. These are the tried and true methods that work out in the community. They work in doctors' offices, and we want to bring them to our schools. We're not doing this to be intrusive. I suggest to you, today that we're doing everything we can in our power in the legislature to try to combat what we see in our communities and try to help the families that we represent, but we need your help. And I know that I'm here to give welcoming remarks, and I will get off my soapbox. I deal with this each and every day, so if I start talking in acronyms, I apologize. But the truth is that it's forums like this. It's times like this when community members come together, and I will tell you, I've been to many. This is one of the best attended forums that I've been to. And it really pains me to think that we can't fill auditoriums with people wanting to talk about this issue, because I guarantee there are people at home who think about this and have this problem in their own houses that are afraid to get help. One of the most common phrases I hear is, "Senator, I need help, but please don't tell anyone. Please don't let anyone know it's my child. Please don't let anyone know it's me." And I think we have to start breaking that stigma, because you are no different than everybody else. In 2013, I had shoulder surgery, and I got 40 Percocets for a simple shoulder surgery, something that they do each and every day. And when I only ended up taking 4 or 5 of them, you have to figure out how to dispose of them. I will give you this one fun fact, if there's any fun facts with regards to addiction. One of the most common places to obtain drugs is a real estate open house, because nobody thinks to clean out their medicine cabinet, but they think to clean up their living room. So there are people that have gone in, and the governor and I just spoke at a forum for what's called the Safe Homes Coalition to talk about just that. People are going everywhere to get drugs, and nothing is immune from it. So tonight, I hope you really engage in the conversation. You have great panelists here from all parts of the community that we're willing to work with. And if there's ever anything that we can do, Representative Hogan or I, please let us know, because we are in this together and we really want to do the best that we can. So thank you.
Thank you, Senator. Senator Flanagan has truly been a leader in the drug abuse campaign on Beacon Hill. She has led many of the pieces of legislation that are moving through now, and many that have gone before, and she is tireless in her efforts, truly. And whether that means being on the cell phone, getting a bed, or standing up in the Senate and speaking as she just did so very eloquently. And so thank you so much, Senator, for all the work that you do. I'd like to now introduce Corey Welford. Thank you so much for being here. And he is the Chief Counsel to Attorney General Maura Healey. Come on up, Corey.
Thank you, Representative, and thank you for your leadership on this issue. I also want to say it's nice to see DA Ryan here. I used to work in the DA's office back when Marion was an ADA, and I can tell you that before she was DA and now as DA, there's no one that is more committed to helping victims of crime and helping families in her county, and just want to thank her for being here today. So I am glad to be here to represent the Attorney General's office. The AG asked me to be here because this is such an important issue. You'll hear a lot of stats and a lot of numbers here. I'll just share a couple to show the scope of what we're facing as a state and what families are facing right now. Last year alone, we lost 1,200 people to opiate addiction. That's more than we lost to car crashes in Massachusetts. And in the United States, we represent 5% of the world's population, and we consume 80% of the world's opioids. 5% of the population, 80% of its opioids. This is an issue that's impacting every community and every family really across the state. I can tell you Attorney General Healey has made this her top priority. We've been working on this in a number of different ways. We recently entered into an agreement with the maker of Narcan, which is a anti-overdose medication prescription. And through that and a fund established by the legislature, we've been able to make that life-saving drug much more affordable and accessible to first responders, so that as they're going out to calls, that they'll be able to have this drug more available to them to actually try to save lives when they do these responses. We've also filed a bill to make fentanyl, the trafficking of fentanyl, a crime. Fentanyl is a new synthetic opioid that we've started to see growing and expanding at alarming rates in Massachusetts. It's 50 to 100 times more potent than heroin. And what we've been seeing out on the streets is that people have been lacing and mixing fentanyl with heroin, and the people who are using don't even know that at the time. So we filed a bill to make trafficking of this crime, trafficking of this drug a crime, and we hope with the work of the legislature to get that passed soon so we have an added tool for our first responders and our police to try to combat that. The most important thing that we can do and what we've been focused on is making treatment more accessible and working on the prevention side. And I can say that's why forums like this, hosted by the representative, are so important. On a personal level, I'll say our family, my family is dealing with this issue now, and I can tell you the road to recovery is not a straight line, and there's no playbook for trying to help those that you love deal with this. And so I think what you're doing right now, to all of you, trying to educate yourselves is the best thing that you can do, and then trying to be there for your loved one to help them in any way that you can. This is such a good start, and it's such an important thing that you guys are all here today to try to help the people that you love. So I just want to tell you to keep it up. You're doing the right thing, and you have some great people here that will help you along the way. And the Attorney General's office is here to help as well. So thank you.
Thank you, Corey. So we will start with our panelists, and when, oh, DA Ryan, welcome. Come right up. Thank you for making your way to Maynard. Sometimes it can be really tough. So I am happy then to introduce the Honorable Marion Ryan, a Middlesex County District Attorney. She's our first panelist for the evening. She has spent more than 3 decades prosecuting serious criminal investigations, advocating for victims, and creating innovative crime prevention initiatives. District Attorney Ryan is recognized for her leadership on the opioid crisis and her innovative programs that address all aspects of abuse and addiction. In fact, she was just at our briefing that we had yesterday at the State House talking about best practices and innovations through the Middlesex County District Attorney's Office and all that they've done. So without further ado, what I would like to do is introduce DA Ryan and have her speak to the issue of opioid addiction. You can speak up at the mic or at the table.
Thank you, Representative Hogan, and thank you to you and to Senator Flanagan and Representative Malia, who really have taken a leadership role on this issue. And I'd like to speak a little bit about the Middlesex experience, which, because we've been doing this for quite a long time now in Middlesex, and it all started about 4.5 years ago, close to 5 years now, when I began to see a little bit of an uptick in opioid-related deaths, primarily up in the Merrimack Valley. And that caused us to start to wonder what was going on. And of course, we had no idea at that time that this would become such a national problem, such a serious problem here in Middlesex County. So the first piece in educating yourself about this really leads you to the conclusion that this is not just a public safety issue in the way that we had very often looked at drug-related cases, but that it really was a public health issue. And to make sure that we kept that focus, when we were starting this process, I started with hospital-based task forces. So it was a task force based in the local hospital, bringing to the table literally everybody who would be involved in these cases. That meant the law enforcement, it meant social service providers, it meant medical professionals, it meant probation officers. Everybody who was going to have to interact and deal with these situations came together to start assessing what we had, figuring out what we should be doing, and kind of moving forward in terms of how we would address this issue. And obviously, there were pieces that were immediately needed. The prevention piece, and we began lots of prevention work in the schools, lots of things about funding with drug forfeiture money, substance-free nights, the kind of lockdown nights after prom or after graduation, that sort of thing. It meant really collecting the medication. About 4 years ago, we began partnering with the real estate officials because we knew, and you don't have to raise your hands, but I would suggest that probably 80% of the people in this room, if you thought very hard about what's in the back of your medicine cabinet, there is a bottle that has a couple of oxycodons or some kind of painkiller that you got at some point. You didn't need to finish that prescription. Maybe you just held on in case you had a problem with that after-surgery process later on. And they're sitting in the back, and you are not going to miss those if they're gone. So if you have somebody who's coming through your house on a real estate open house to look at your house, or you have some young people in your life, your children, grandchildren, who are experimenting, it's a very, very easy place to get those. So about 4 years ago, we started that partnership with really talking to the brokers for two reasons. Number one, because they could educate their customers, and secondly, because they also have a very good base in the community, and they could start spreading the word about what was out there and what was really something people needed to be a little more conscious of. Not only what's in the prescription medicine cabinet in terms of real estate, but very many of us have some medications we take every day we don't want to forget. They're lined up on the windowsill, they're lined up on the night table. They're very easy pickings for somebody coming through the house. So there was that prevention piece. There was the education piece that we were getting out to students, to parents, to teachers. And there was also, what very clearly was needed was the treatment piece. And because we were working in hospital task forces, that was an easy jump off to start looking at what could we do in terms of treatment, what were we able to do. For instance, with our Lowell task force, we were pretty quickly able to work out some arrangements that got us some extra treatment beds at Tewksbury State Hospital that was able to alleviate some of the pressure. And, one of the frightening things really is that as much as we in Middlesex County are always looking for beds, we actually have a fair portion of the state's beds in this county. So there are parts of the state where there just are no beds. So that is the constant need. It also meant really educating ourselves about what kind of treatment beds were effective. Were we talking about detox beds? Were we talking about recovery beds? Who needed what was going to be covered? And really helping families to navigate that. I think even if you are experienced in insurance and in healthcare, that is a difficult process. So for a family in crisis who probably does not have that experience, it is almost insurmountable to make your way through what is the best thing to be doing. And many, many parents will come and say, I took my child to detox. They're going to be there for a week. It's at a nice hospital. We are paying for that, and then we are going to be all set. That detox road is only the beginning of the journey out of addiction. And also we were looking at enforcement in terms of just making choices about where our resources in law enforcement were going to go. The unfortunate reality is that this is a very lucrative business. There are many, many people making a very generous income off the misery of others. And that's where we have really focused our resources in terms of the narcotic operations that we are conducting. They are focused on people who are bringing very large amounts of products, whether it's kilos of heroin or it's thousands of oxycodone pills. And it is a business. There should be no mistake about that. Recently, we made an arrest in a case where there were thousands, literally thousands, of oxycodone pills coming in every day. And to conduct that level of business, these are not people who are using themselves in the throes of addiction. They could not be to operate the schedule that they are operating on. In this particular seizure that we made, we had an individual who had, because, like most businessmen, decided to explore what was going to be the cheapest and quickest way to move his product, and he had found that that was through the mail. So we had a system set up where he had rented those post office boxes at the little mail stores that are everywhere, and he had a very rigid schedule every day. And every day he would receive at those post office boxes one of those priority envelopes. Everybody sees them. They don't attract any attention. And it was filled with oxycodone pills, but only one. So nobody was suspicious that he was getting one package at that box. He would make a circuit, just like a mailman. He would go to the box, he would pick up that envelope full of pills, and within 1 hour, he had made a sale of those. So he had moved his product pretty efficiently. He had minimized his risk because the thousands of pills were only in his possession for under 60 minutes, and he was receiving a very handsome profit for that investment. So that arrest led to a seizure of a very large supply, both in his car and at home, of those pills. But what we know is that as soon as we're taking it off, there's another set coming the next day. So that is a struggle. That is a constant struggle for us in terms of looking at that high-level movement of product. The other piece has been really partnering with our legislative partners in moving forward some of the legislation. We proposed a bill, and there are packets that are available for folks, but legislation that, first of all, would limit to a 3-day supply what you can get if you go to an emergency room or one of these pop-up kind of minute clinic, bone shops, all of these places where they're targeted by people who are looking for medication, because it's somebody that you don't know, you don't get to have a very big relationship with, and it's pretty easy to pick up a prescription there for a very large supply sometimes. So we're looking to limit that. You fall off a ladder on Friday night, of course we want you to be able to go to the emergency room and get enough pain medication to get you through the weekend. But we also want you going back to your primary care doctor who knows you, who knows your history, who knows what other scripts you may be on, and can make a good determination about what they should be prescribing. To that end, we have also brought in, we've partnered with Boston University School of Medicine with their scope of pain training, which really teaches doctors, physicians' assistants, anybody who can write a script for opioids, the kinds of questions they need to be asking, the things they need to be considering when they're writing those scripts. There certainly are people who have conditions that require them to have those scripts, but those should be identified. There should be questioning about history, all of those kinds of things that we need to know before you're responsibly getting those kind of scripts. Because we continue to respond to overdoses and find prescription bottles written by physicians that have 120 or 150, or they had 120 or 150 opioid pills in them. They're expensive, so people are selling them, making a profit on them, and they're also very available to overdose on. So that is a piece that we need to be closing the loophole on. We've also targeted some of the synthetic drugs, particularly the N-bombs, which is a synthetic LSD. Those are all gateway kinds of drugs. The N-bomb drug is available in the tabs. They look like a postage stamp. They sell for about $1. They're also very easily concealable in kids' pockets, in their book bags, all of the places where you're not going to immediately see those. So we're targeting those pieces of legislation. We're also looking at the immediate intervention. We have used drug forfeiture funds to provide for every city and town in Middlesex County a seed dose of 10 of Narcan, so that we trained first responders across the county in how to use Narcan. We provided every city and town with that Narcan. It has been my hope, and we have been largely successful, that once cities and towns began to see the effect that that could have in, it's not treatment, it is not prevention, but it does allow someone to survive an overdose and live to the next day when hopefully they'll get to a treatment place. So we have largely been found cities and towns willing, once they saw that effect, to start responding by funding. We have continued from the supply we have to fund as much as possible. Today we began the outreach this afternoon. We had a group of teachers, principals, athletic directors, and coaches who came to our office where they were trained by a doctor on the medical side of Narcan, and then also taught much the same way if you go to learn the Heimlich maneuver or CPR with the dummies that you use, they were taught how to administer Narcan. Because we know that in our schools we have kids, we have staff, we have parents, and we have also discovered as some of our Narcan was being used in the schools, that many times people who might be with someone who's experiencing an overdose treat a school as I would think you might have taught a fire station or a police station. They believe there might medical help there, so they'll arrive at the front door of the school. They have no particular connection to that school, but they will arrive there with somebody who's in an overdose. So though we are now training all of our schools to be able to administer Narcan, to be able to intervene in those situations. But all of those efforts, and many of my colleagues across the state have been doing a number of those pieces, they are what we need to be doing on the ground to be dealing with the crisis. But about 6 or 8 months ago, one of the concerning trends that was clear to me, and as Representative Hogan said, I've been a district attorney for a long time. I have seen the change socially when we have focused on things like drunk driving. When I started in the district attorney's office, we had well over 2,000 drunk driving deaths a year in Massachusetts. That number now hovers at about 250, 275. Because of things like Mothers Against Drunk Driving, a change in that whole view. I remember when we smoked in our offices. People don't do that anymore. So there's been that focus of resource and a change. The very troubling piece of this epidemic is you cannot pick up a newspaper or turn on the television without hearing people talking about what they're doing about the opioid crisis. And yet that number continues to go in the wrong direction. So as of this weekend, my office had responded to 161 fatal overdoses across the county. And when you look at the map that's referenced, it's in the packets that we brought for you, there's a map that gives you the entire county, and it indicates deaths in those towns. I represent 54 cities and towns. There are less than a dozen that have not experienced a fatal opioid overdose. So it shows you where it goes. It also, if you took this map and you overlay on this a state highway map, you would see how much of it is reflected by people traveling, perhaps leaving an exit, being in a fast food place that might be at the exit, an exchange taking place, and then an overdose. So that's also a significant piece. So what does that tell us in terms of what we need to be doing? We need to be doing all of those things we just talked about. We need to be doing the prevention, the education, the outreach, treatment, intervention, legislation, all of that. But more than that, we need to be able to, at some level, go almost to the 30,000-foot level and think about what this means in terms of this is not a crisis that's ending in 2015 or 16, in all likelihood. We are in this for a longer term. And with that in mind, we have shifted some of our focus to some of those longer-term approaches, and particularly two, one of which is I have had my troopers respond to any number of fatal overdoses where what we have found is that there is a child there, sometimes a toddler, sometimes a second or third grader, who has witnessed what is taking place. So you don't have to really think very hard to consider that that child who at 2 o'clock in the morning has maybe been knocking on the bathroom door, mom hasn't been responding, the door's eventually opened and mom is in an overdose and doesn't survive that overdose. You don't have to think very hard that that child is not likely to be going to second or third grade tomorrow and behaving in any acceptable way or making any kind of educational stride that we would want for our children. So to that end, in thinking about what are ingredients to all of that, which is, number one, the trauma of what they've witnessed, the loss of that parent or caregiver, the fact that for at least some period of time that child has been living in a home where drug use has been normalized, what we know about the genetic predisposition, and the pain that that child is going to be in, which they may choose to self-medicate. So we cannot, as responsible adults, be very surprised when 5, 6, or 7 years from now we're seeing that child using and coming through the criminal justice process. So to that end, and to be able to intervene effectively, we have begun a program starting primarily with our police departments that have an embedded mental health worker to, regardless of the hour when that occurs, have that embedded mental health, trauma-informed mental health worker responding to the scene to deal with that child. We've had the unfortunate reality in the very first week of when we began that, of having that experience where there were some preschool children present. We were able by that morning to have them in play and art therapy, beginning to address that trauma. So that is something that we owe to our children. something that we are going to be putting some of our resources on because, again, it is something that we know going forward is going to be an issue. The other piece is looking at the sustainability of the amount of resources. You look at the caliber of panelists you have here tonight. You heard from the Attorney General's office. You see from our legislators from our office. So if you think about the amount just of pure work hours every week that are being used to address this issue, and then you overlay on that the dollars being spent, that is really not sustainable. So we have to be making very wise choices about where we're putting the money, what kind of treatment is really effective. Because when you look, and this is a very disturbing part of this whole process, when you look at the treatment options, look at what we consider sort of some long-term sobriety at about 5 years, the treatment success rate of a number of programs, the vast majority of programs, is pretty low. And we know that this is an addiction that is riddled with, as Corey Welford said, it is not a straight road. So we are building into that the fact that most people who make it to that long-term recovery, virtually everyone, will tell you they had 6, 7, 8 attempts at treatment before there was a successful treatment. So we really have to know what kind of treatment is effective and where are we putting our resources. And it became clear to me that as well-intentioned as many of us were, we were also often dealing from the outside. We were looking at this and we were saying, someone, for instance, and we discovered this to be a great myth, somebody who has been Narcaned will be incredibly grateful and want to go straight to treatment. We have discovered that that is not true. So, and the other piece of it is that people want treatment and they just can't necessarily get to it. We've discovered that very often the family wants treatment, but the person in the throes of addiction is not really interested in treatment. So to try to get us to that next level, we have organized and have begun presenting across the county our mobile opiate forum, which is led by a doctor who has himself dealt with addiction both as a medical professional and as the parent of someone in recovery, who gives really an opportunity to discuss and explain in ways that I'm not sure all of us have a real understanding of what opioid addiction means in terms of the physical piece, not only of what withdrawal is like and what the addiction is like, but what it physically does, for instance, to your brain and what kind of time frame is needed for healing. I think that helps us to inform what kind of treatment's really going to be helpful. If you hear the doctor talk about the lesions and things that happen to your brain and how long it takes for that to heal, it then becomes pretty clear that the 5-day treatment that sounds great is not going to be what you need. So he talks through that piece. We then have the administrator for the drug court talk a little bit about what some of the treatment options are, what's available, what treatment beds really mean, what's a recovery bed, what's a detox bed, all of that piece. And then perhaps most important, we have 6 individuals with us who are in various stages of longer-term recovery. Really, and as you heard earlier, when you think about who it is that this problem affects, if you ever were uncertain about that, when you see on the panels that we have, the folks that come with us, we have a postdoctoral student at MIT. We have a woman who spent a very long part of her career as a med-surg nurse herself. We have a nursing student from one of the most prestigious universities in Massachusetts who talks about the fact that she went through 3 years of class using opioids every single day. It gives you a very different perspective. It helps you as parents to think about the things you need to be talking to your kids about, the things that you need to be noticing. For instance, the doctor speaks about the fact that one of the things was he began noticing that spoons were missing in his house. And he believed that was because the kids were always taking bowls of cereal and leaving them in the family room and leaving them wherever. And even as a medical professional, he was not identifying that as an opioid piece. So that piece and that talking really, I think, informs where we go in terms of what's helpful in terms of education, in terms of prevention, and most importantly, in terms of treatment. So that is the focus that we are looking at now in terms of dealing with this longer term problem, as well as keeping going all of those programs that we've developed that address the immediacy of it. So again, I applaud you for being here tonight. You know, one of the most important pieces is getting this information out. One piece of the governor's bill talks about requiring parents to be present for a discussion about opioids at their child's school. That is something now that is important. You know, if we put up a sign, I suggest, that said there's some kind of contagious disease going through the school, we would fill this auditorium. We would fill auditoriums across town. And we aren't doing that. And we need to be doing that because it is every bit as much of a public safety threat, a public health threat to kids as this opioid crisis. So I really applaud you for being here tonight. I look forward to joining with our panelists and to answering the questions that you might have. Thank you. And again, thank you to Representative Hogan.
Thank you so much, DA Ryan. We're very grateful for your time and for your remarks as well. I would now like to introduce our next panelist. The Honorable Chief Justice Paula Carey was appointed Chief Justice of the Trial Courts in July of 2013. She was appointed an Associate Justice of the Norfolk Probate and Family Court in 2001. She has lectured and authored material for numerous publications and educational programs in the area of domestic relations, both as a practitioner and as a judge. It gives me great pleasure to introduce the Honorable Paula Carey.
Thank you. Good evening. I'd like to say I'm delighted to be here, but I'm not so delighted to be here to have to talk about this particular issue. And you may be wondering, you know, why the heck is the courts here, and how does the court intersect with the opioid crisis? But we do, and we do in a very real way. 95% of our criminal cases involve some sort of substance use issue. So daily in our courthouses, we are seeing people who are criminal justice involvement, who are addicted in some way to some sort of substance. So as a society, we really do. You've heard it. We face unprecedented challenges in this area, and it's something that the court system really has felt the need to become front and center on beginning to deal with it. And then when you throw mental health issues involved, and many individuals who have substance use issues have mental health issues as well, it becomes clear that we as a court system we can't conduct business as we have always done. And it's my firm belief that neither the executive branch, the legislative branch, or the judicial branch can confront this problem alone. I'd like to thank Senator Flanagan, Rep. Hogan, Rep. Malia for their incredible work. And I learned a lot of things today from DA Ryan in terms of the wonderful work that she is doing. So our efforts in the court system, just so you know, how do folks who are addicted come into our system? They come into us because they've committed a crime. I think more and more our judges and those who are involved in our system view individuals who are addicted to opiates as having a problem, and that many are committing low-level crimes, not the traffickers that DA Ryan is talking about, but many of the individuals, we see those and we view those as in an entirely different category than we view the individuals who are breaking into homes or who are stealing your jewelry, stealing your money just to feed their habit, because we see them each and every day. It often feels like our court system, we've become almost like an emergency room. You know, I hear my court officers saying, but what do I do? I've got someone who's going through withdrawal in my lockup. They're in my lockup. We don't have medical degrees. Frankly, ultimately, usually we end up calling we end up calling calling an ambulance and that happens daily in our courthouses, daily. So we get people who have committed crimes. Many are low-level crimes, and many commit crimes on a regular basis. So they start off with one crime, and then before you know it, they've got a record with 10 different offenses, which in a very meaningful way changes what a judge might do in terms of disposition. You've heard today about that the first time generally doesn't take if we can convince someone to go into treatment. It generally takes many times for them to have it take. So our hope through the court system, and one of the innovative, actually it's not so innovative at this point because drug courts have been around for about 20 years. Massachusetts was on the cutting edge 20 years ago, and then we sort of fell off the radar. The opioid, we still had some drug courts, but there wasn't a lot of, it was because certain judges and probation officers were particularly interested in them. Now as a system, we are, and we're incredibly grateful to our legislature and our executive branch for funding, for providing funding to the court system, although this is, I mentioned earlier that all of tackling this opioid issue really takes a coordinated effort. It can't just be one particular individual, and we can't be siloed as we begin to deal with these issues. And this is unique across the country. The trial court has been working in a very significant way with DPH and the Department of Mental Health in addressing these issues in a way that can help not only those who are criminally involved within our court system, but for those who suffer from addiction and are a danger to themselves and a danger to others. They, in the area of specialty courts, our budget request, and we've received $3 million from the governor and our legislature to fund our drug courts. Most of that goes towards beds and goes towards clinicians, so that we have clinicians who are better able to assess individuals who come into our courts in a way that we can divert them or put them into the right treatment program for them. The DMH will cover the clinicians, DPH will cover the beds, but you've heard today, and I think you're probably going to hear more about the fact that for every individual that comes into our system, we are clamoring for beds. It's not unusual to have judges calling on the bench. We never thought that this is part of a job of being a judge, but we're on the bench and we're calling treatment providers to try to get a bed because you see an individual before you who is sick, very sick. Putting them in holding them, many of these individuals, as I said, if it's a low-level crime, we might not put bail because we expect that they'll come back. So it may be some way that we can get them into some treatment to secure that they will come back and reappear if it's criminal. So the other way, besides committing a crime, that individuals come into our courts seeking help, and it's usually it's something that we call civil commitment. If you hear people talk about Section 35, it's actually Mass General Laws, Chapter 123, Section 35. It's a mechanism where a loved one, a physician, a probation officer, and a number of other individuals can actually petition the court for a civil commitment. It means that that individual has not committed a crime, but that they are a danger to themselves or a danger to others. I have to tell you that it is one of the most heartbreaking things to see, to have a family come in to court seeking to have a loved one be committed. Years ago in the court system, it was primarily individuals who suffered from alcohol abuse, and they would come in and it was generally older individuals. I have to say now it's not so much. It's young people between the ages of 17 and 30. That's the vast majority of the individuals that we're seeing now. And they are very, very sick. And people, the parents or other individuals come to us with the most horrific stories, begging for help because they haven't been able to find a resource themselves. It's not a place where the court system really wants to be, but it's a place that we feel like we have to be for public safety. Many times it's public safety. This person potentially is a danger to the community. So it puts us in a situation where we have to do something, or they're going to do something to themselves. We are fortunate enough, and we in the trial court are very data-driven, so our specialty courts and our drug courts, we also have mental health courts and veterans courts. What's appropriate for tonight's discussion is more the drug courts and our veterans treatment courts, because many of the veterans that we have, we actually just opened 2 additional veterans courts this week, one in Lawrence and one in Holyoke. And many of our veterans who have given their lives for all of us to serve us and protect us come back to us in a very damaged way. And many have substance use addictions that we are dealing with in our veterans treatment courts. So in terms of data, we are ensuring that our specialty courts are actually well worth the investment by reducing jail days, by putting people into treatment programs that actually help and work. Let me explain what a drug court, for those of you that don't know. It's actually very intensive. You begin when you get chosen. Our drug courts in Massachusetts are primarily post-disposition. So it means that instead of going to jail, a judge will say to someone, we have this opportunity for you to enter into our drug treatment court. Now, mind you, in many cases, if it's a relatively low-level crime, it's easier for the person to go to jail. But the outcomes for someone who is addicted in jail are horrible. When they come out, they still have issues. They are now back into our community, as Senator Flanagan said, and they go right back to it. They go back into the same areas. They associate with the same people they used to associate with, and it doesn't work. They get right back into that cycle again. So what we do in the drug treatment courts is you enter into that program. There are many conditions. The conditions are generally that you're either in an inpatient program for a period of time, then stepping down into an outpatient program. It might be you're in a halfway house for a period of time. The enrollment in the specialty courts generally goes from 12 to 18 months. Those individuals are required, at least for the first usually 4 to 5 months, to appear weekly to the judge. What happens is that there's counsel for the individual. The DAs are involved. We have treatment providers who are involved, probation involved, the judge is involved. It's very different. It's nothing like you'll see in TV at all, because the judges, it's more holistic. The judges hold individuals accountable. We expect that there'll be a relapse. We don't expect that individuals are going to be able to get through this. It's hard. It's hard work. But if you've never gone to a drug court graduation, you've got to go, because it is the most incredible experience. You're not human if you don't have tears in your eyes as you watch the incredible progress that these people have made. They put their lives back together again. And in doing so, they get back into the community, they get back involved in their own families, and they become functioning members of society. We help them get jobs, we help them get GEDs, we help them just get their lives back. So it's an incredible opportunity for the court system. It takes great dedication. Often you'll hear individuals, if you go to a session, not necessarily a graduation, you'll have a judge or a probation officer talk to these folks, and it's the first time that someone's actually said to them, "Good job. Good job. You made it through the week. You made it through the week, and you didn't use." It's just a wonderful opportunity, and we expect one of the aspects of specialty courts in Massachusetts, which is a little unique, is, and thanks to our legislature, we got funding for something we call a Center of Excellence, which helps us with our metrics, helps us measure the recidivism, help us actually look to ensure that what we think we're doing anecdotally is actually what we're really doing, which is we're improving outcomes for individuals who have criminal involvement, and we are reducing recidivism for these individuals. And so therefore, it reduces jail days, saves the Commonwealth money, but most importantly, we get people back into the communities and functioning. The more difficult area is the Section 35, which, as I said, is not the area that the courts, the involuntary commitments, it's not an area that the courts really want to be in. I served on the governor's opioid task force, and I remember debating all of this with all of the incredible people who were on that commission. We filled auditoriums and heard heartbreaking stories of individuals who either suffered from addiction themselves and kicked it, were currently suffering from addiction, or had family members suffering from addiction. And time again, those individuals who came out on the other end, they would tell us, you need to put us in a locked facility, because if you don't, we will leave. We will leave. And that's the challenge, is to actually get people, because, it's hard. We don't want to put individuals who haven't committed a crime in a prison. It's just not comfortable. We're working on, right now, women actually go to Framingham, to the state prison. We're working on coming up with a solution to ensure that no longer happens, and that we have secure places for women that are secure. Even if it's staff secure, that means they have appropriate staffing to be able to keep people in the treatment as long as we need to keep them there. So we're working on those kinds of things, but they're difficult. In the involuntary commitments, they're awfully difficult. Generally, a judge will commit someone for 90 days. They don't stay. Generally, they're discharged after the average stay is about 21 days, and that's not enough. It's not enough to keep people in a sustained effort to be able to, if they're addicted, if they're truly addicted, then it's just not enough. So getting the right assessments in place to get people to the right place and the right step down is what this is really all about. The last thing I'm going to say, and hopefully I explained, it's complicated, and I'm happy to answer questions about Section 35 because it can be very complicated. The last thing I'm going to talk about is a sustained effort that the trial court is rolling out with our executive branch partners, with the support of the legislature, because the legislature funded, and the governor just signed a supplemental budget that has given us a staff person to help us with something that's called sequential intercept mapping. And what that is, and we're rolling it out in connection with the rollout of our specialty courts. We have 34 specialty courts, 26 of them are drug courts. And in connection with opening new courts and then going back to our courts that are already opened, what we do is we conduct a sequential intercept mapping. We know that individuals who connect with the criminal justice system do so in predictable ways. They begin post-arrest. So that's an intercept point, so sequential intercept. If you look at the 5 areas of interception, it's pre-arrest, it's arrest, it's arraignment, it's conviction, and then it's release from jail. So at each level, at each intercept point, we have an opportunity. We have an opportunity to divert individuals to treatment. So what we do, and I'm convinced that the one thing that's actually going to crack this is going to be it's going to be done at a community level. We can do everything we want out at the higher level, and all of that is really, really important, and we have to do all of that too. But to actually solve this problem, we need to do it in the communities. So these sequential intercept mapping, we bring police, we bring our partners in law enforcement, we bring DAs, we bring our providers, we bring the court, we bring everyone we can think of to actually come to the table. And when we do these mappings, we have a facilitator. We have about 50 people, 50 community people, and we work on, so what resources do we have? Where are our gaps? So what are we going to do about that gap? How are we going to fill that gap? How are we going to be able to, and how do we collectively find those points and be able to divert people into treatment from all of those areas. So we've just gotten our funding. We're going to advertise for that position, although it hasn't stopped us. I've been using trial court employees to try to do it, but I have to tell you, it's a huge effort to get the right people at the table to be able to have these discussions. It's really been a tremendous effort. Our hope is when we're done that we will have a sequential intercept mapping for the entire state, drilled down to each community so that we know what we have. You know, it was interesting, one of the first intercept mapping we did was in Quincy, and we found 15 beds that we didn't even know existed. So by doing this, we're identifying resources so that we can help individuals who are substance involved. It shouldn't be a stigma. We're looking at it differently now. We in the system are looking at it differently. Trafficking, well, we look at those people, you know, we don't look at those in the same way, but individuals who really, truly are addicted, and most of the time, or many times, not all of the times, but many times the addiction is driving the criminal behavior, and has for many years. So I'm going to leave you with that and just say, again, it's a collective effort. Not one of us can solve this problem alone. We really have to work together. And frankly, we need your help. We need you to talk this up in your community, make people aware of the public health issues, make people aware of the signs and the symptoms. Don't ignore it in your families, and don't if you see some friends of your kids, don't ignore it. Help them, help the parents. Make it okay for them to talk about it, and make it okay for the kids to talk about it. So, I'll close with that. Thank you.
Thank you so much, Judge Carey. Thank you for your service as well. It is now my great honor to introduce one of my good friends in the state legislature, State Representative Liz Malia. She represents the 11th Suffolk District and has served as the chair of the Joint Committee on Mental Health and Substance Abuse for many, many years, and has been a key player along with Senator Jen Flanagan in putting legislation together over the last 2 years, and as we move forward with our much larger bill that will be coming out during this year's session. So welcome, Liz Malia.
Evening, everyone. Thank you for coming out tonight. I just have to say, first of all, thank you so much to Rep. Kate Hogan for inviting me and for providing an opportunity for all of us to come together. It's really an honor to be here speaking to community folks who are beginning to, respond and understand part of what's happening to us in the opiate epidemic. But it's also an honor to be with D.A. Ryan and Judge Carey. And I tremendously applaud Rep. Hogan as the committee chair of Public Health and Senator Jen Flanagan, my co-chair in the Mental Health and Substance Abuse Committee. These women particularly are incredibly knowledgeable, hardworking, and I think have some of the answers we're looking for. Not all of them, but some of them. And I want to just say right off the bat, because I think this is an important part of this, I am a person in long-term recovery from alcohol and drug use. I am fortunate to be here, to be alive. I lost a family member when I was about 25 years old. I lost an older sister who was, this is 40 years ago, a long time ago. The face of addiction has changed. I was fortunate to find people that helped me. I learned I had to ask for help, but I also learned that this is a disease. And I particularly have learned more recently how insidious and how incredibly powerful this disease is. District Attorney Ryan spoke to us yesterday in the State House, and she was talking about the fact that this is, what some of us are used to and what I probably experienced was, not the type of danger that we're seeing out there now. The types of drugs that people are experimenting with or exposed to, especially young people, are far and away more addictive, more powerful, and extremely dangerous. A lot of younger people engage in risky behavior initially, like, with alcohol and smoking cigarettes, et cetera, et cetera. Nowadays, some of the things that they're exposed to are much, much more frightening. And I think that's one of the things that's really been helpful, is to know that, we've really been exposed to an epidemic, and it's a silent epidemic, and it's invisible, but it is much more fatal now than we knew of before. Unfortunately, it's taken a lot for us to begin to understand why this is so serious and what kinds of risks we have. We're getting to a point where, in spite of all the losses we've heard, and you heard some of the statistics tonight, 1,089 Massachusetts residents died from opiate overdose, a 63% increase from 2012 and 20% over 2013. The first half of 2015, we've had 684 deaths, 6% increase from the same period last year. Even more than that have had their overdoses reversed. In the legislature and in the executive branch, our governor, in our public safety areas, in the courts, as you heard tonight, we're beginning to understand how vast the problem is. But we have, again, we don't know how big the problem is yet. So we're working on, as much as we can, slowly and surely, trying to do things like we've just passed a bill last year that's going into effect now that will guarantee that anyone who is admitted to an emergency room gets at least 2 weeks of insurance cost. I know some of you will have had experiences like this where you've reached out and or you or your family members have reached out and have had difficulty getting approved for insurance coverage. October 1st of this year, we were able to mandate that at least the first 2 weeks are covered. It's just the beginning. It's just the beginning, as you've heard before. The road to recovery is a long one, and it's absolutely involves recidivism and failure. If we don't provide the supports throughout the system, we're not going to be successful at this. But we're learning a lot more about it. Again, one of the things we've been able to do is look at funding programs like Vivitrol programs, which will a drug that can be used basically to inoculate someone against the effect of opiates for at least a month. Some of our law enforcement areas are starting to really pull that in. Barnstable County Jail, which I visited a few months ago, is working on a program to get people who've been incarcerated, who have substance abuse issues, involved in this in their own recovery, and then when they're ready to be discharged, hooking them up with they get Vivitrol that will give them coverage for a month, and they hook them up with community-based services so that that person is getting follow-up, they're getting care, they're getting referral, they're getting the help that they need. Just backing up a little bit, one of the things that's very, very discouraging in many ways is the fact that some of the costs that we are incurring to provide resources seem overwhelming. But what's even more important is thinking about the fact that every person who's incarcerated, and the statistics I've heard are that 60 to 80% of people who are incarcerated have a pre-existing drug and or mental health problem. it costs somewhere in the neighborhood of $47,000 to $50,000 a year just to house them physically in a jail cell. That doesn't count what it costs to do treatment, and it doesn't count what it costs to reintroduce people back into society. So, you know, again, one of the jobs we all have is to try to weigh and balance how much we are willing to spend and to work to address this issue in a more effective way. State and local governments have roles to play, but we didn't all understand what that was before. We had a Department of Public Health, we had a Department of Mental Health, we had a Department of Corrections, we had Department of Education. We didn't all work together. And I think what we're seeing now is a willingness to move past that, to work with the courts, to work with our law enforcement community, and find ways to address in a much more effective way the problems that we're seeing. Just a couple of other things that I'll put out there that are really helpful is the fact that we now have 5 recovery high schools in Massachusetts, something I personally think is an incredibly important part of the formula that we're looking for in terms of recovery and addressing the severity of this problem. We just opened the 5th recovery high school. I'm hoping that very much that we can begin to do this on a broader level so that each geographical area of the state has a recovery high school. The recovery high schools, I attended a graduation from Recovery High School in Boston this past year. My staff member, Margaret, who's with me tonight, and I can't tell you how overwhelmed I was by the wisdom, the strength, and the courage. These are high school kids who otherwise are a prime, they're prime statistics for fatality. Their lives are just beginning, and they're up against some incredible odds. So there are places, and there are ideas, and there are resources that work, and we're hopefully working all together now in terms of state government and in terms of our community resources to begin to make some real headway against this issue. Again, we don't have any easy answers. We don't have a quick fix. There is no magic wand that's going to fix in the near future. We will continue to have deaths. Apparently, it really looks like, as much as we're trying to reach people before they're in that crisis, we haven't gotten all the mechanisms together to do that. So, we need your input and support, but we also need people to understand, and I think this is personally, for myself, I think this is very important to understand. There are resources available to all of us on a very local level. 12-step programs, NA, AA, Al-Anon, are in every community. They're free. You can find out about them online. We'll hear in a few minutes from somebody from a program called Learn to Cope, which is a program that has begun to step up to begin to answer some of the needs that families of people who are caught up in addiction. Those are resources that are desperately needed. So I don't have any quick answers, but I am very, very happy to be here to engage in this dialogue, because I think the more all of us talk about this and the more we take away the shame that has been associated with addiction, the better off we're all going to be. So thanks again for being out here tonight. I appreciate it.
Thank you, Rep. Maya. Thank you for your leadership, and thank you for your friendship. I would now like to introduce, as we have spoken with our DA, with our judge, with our legislators, and now we're going to speak with our Chief of Police. Our next panelist is Maynard Police Chief Mark Dubois. He has been a police officer for approximately 24 years, starting full-time in Northborough. He's been through Shrewsbury Police Department, and is currently appointed police chief of the Maynard Police Department. He serves in multiple leadership positions, including serving on the Governor's Council on Domestic and Sexual Violence and co-chairing the training workshop group. He's also judge advocate in the U.S. Army Reserves and holds a rank of major. He is currently assigned as a command judge advocate of the 804th Medical Brigade. Welcome this evening, Chief.
Good evening. Thank you, Kate, for hosting the event and for bringing it to Maynard. Obviously, by the caliber of the panel, you can see how important this is to all the panel members locally and across the state. Their participation in this is extremely important, and I think because of Kate's leadership in this, Maynard certainly is benefiting from this with the recording of it, so that we'll be able to play this throughout the month. When I was first asked to be on the panel, I thought to myself, what's normally associated over my career with drug addiction and the impact it has on the community, on families, and on law enforcement? What are the typical crimes that you would run into? And Judge Carey hit on a few of them. Very common over my experience, it would be like a whole neighborhood would get broken into with car breaks. People go through cars, or we have a lot of house breaks, and it's a way for somebody to quickly get some money, go to a pawn shop. We see a lot of like metal thefts, like copper theft. They'll steal metal and bring it to a pawn shop and make some quick money to fuel the addiction. Well, in Maine, we just didn't have that. We don't have those issues. We very rarely have house breaks. Not often at all do we have car breaks, and if they do, it's just one random incident. So we don't have those. I'm thinking back over my career, and when I worked in Shrewsbury, I was a lieutenant in charge of the operations division, so I was responsible for all the patrol operations of it. And for a couple of years, we had such a problem there at a local pharmacy. I used to eat my lunch in the parking lot in my unmarked police car, because people would go in, purchase syringes, go in the parking lot, shoot up, and throw the syringes in the parking lot and drive away. And the manager of the pharmacy would call and complain about that and turn in the syringes. And so I'm drawing on those experiences here in Maynard, and I'm just not seeing it. So I started looking at the statistics for the overdose. And for deaths in Maynard in 2012 was reported through the state. It's a report that the state puts out. We had 2 overdose deaths in 2012. We had 0 for 2013. And we had 2 more for 2014. So I'm thinking back, this isn't a big spike in anything. It seems fairly consistent. And then I came into work on Monday morning, and over the weekend, we tragically had 2 overdose deaths. We had a person 35 years old on Saturday, and then we had a 45-year-old on Sunday. And by reviewing all the reports, and I learned a little bit about these very, very sad cases. The first one, the 35-year-old, he had been battling addiction for some time. And this is what was relayed to the officers. I wasn't on scene at the house, and both of these still have to be confirmed, through the medical examiner's office. But there was obvious signs of the drug use, and the drugs were on scene. So it's pretty certain that that's what was the cause of death. But the 35-year-old had been battling addiction in and out of rehab for several years. And in this particular instant, he was with somebody who had no idea that he was using heroin. And as tragic as it can be, and I can't imagine any worse situation, his parent found him, reported it to us. And I just can't think of a worse situation. Next night, similar incident. And it's the same story that we keep hearing about. It was somebody who had a fairly successful business, had an injury, was prescribed pain meds, and over the course of about 4 years, worked its way up to using heroin and overdosed and died over the weekend. So these things impact every community, large and small, all over the state. And so I'm taking a different look at it and using all the resources we have. And by the way, Maynard and Middlesex County is extremely fortunate to have the leadership of DA Ryan. She's extremely involved, and we benefit greatly from all the programs that she has in the communication that we have with the DA's office. And we feel very fortunate in this part of the state with the leadership that she brings to the table with all this, with this issue. The one interesting thing with this is that the two common factors with both of these cases, the common factor is they weren't really involved with police at all. We weren't really aware of them as far as like the crimes go, as the judge stated. We didn't have any prior incidents that we were really involved with them. So they were fueling their addiction somehow, whether it's through family enabling them or working somehow to pay for it, because it's very costly for a lot of addictions. And over my experience, over my years with this, I find that most addicts that when they get to the real serious, they can't work because they're just constantly trying to find more money to purchase more of whatever their drug of choice is. In these cases, we weren't really involved with them. So that's what's so important about a forum like this, to let the public know and to make people aware of the fact that it could be a family member somehow, some way. And I'm thinking, we've had several cases throughout the last couple of years, and one in particular that they were an overdose, and it was a boyfriend and girlfriend. Girlfriend overdosed, and the boyfriend called, and they were in the house, and the parents were home. And the boyfriend had Narcan on him. And when we arrived, he had already used it on her and revived her. And that was one where we hadn't had any prior interaction with the female. The boyfriend, on the other hand, we had a lot of interaction with. And one of the sad parts of this was he was living with elderly family members and forcing them to give him money and bring him to get his drugs. And we actually did a Section 35 on this when we became fully involved in the issues, because it's extremely difficult and it's extremely frustrating for police officers when we come into contact with addicts. And in this particular case, where the boyfriend had used Narcan on the girlfriend, there was heroin there, and in the way the law is written now is when people report an incident like this to save their life, there's no action taken, criminal action, and it's a very good reason for it, but it does make frustration on the police officer's part. But in this particular case, the male was forcing his elderly grandparents to give him rides and supply his habit. We did a 35. And he was gone for about 2 weeks, and the next time we interacted with him, he had assaulted the grandparents because they wouldn't take him anymore. And he was incarcerated. And the case might still be pending. I'm not sure if he's still out there. But these are the cases, the type of things that we see. So this wasn't an overdose, but it's a pretty extreme case. So every year, police officers receive CPR first aid training as a renewal. So we're required annually to get recertified. And it's mandatory. It's called in-service training, which is provided throughout the state. This year in particular, they spent a considerable amount of time on the overdose problem. And some of the statistics that I learned that I think are relevant is New England compared to the rest of the nation, heroin is by far the biggest threat. It's about 3 times more common in New England specifically throughout the rest of the country. It is definitely the most abused drug that we have in our region. And also, one thing that I didn't really associate with is there's about 20 common drugs that are in this highly addictive category that I never connected all the dots, to be quite honest with you, with all the variety of either prescription drugs or illegal narcotics that are connected. And some of them are like heroin, codeine, OxyContin, Percocet, morphine, fentanyl, methadone. So we do see these on the street, but it's all prescription stuff, which is interesting because it's in a very unique class of highly addictive medication. So in addition to the education that the officers receive with dealing with an overdose, it's just to be aware of it, to recognize it. In Maynard, every police vehicle has Narcan in it. And all the officers, one officer went in and became an instructor, and then in order to keep it in every vehicle, which is the way that we decided to do it, it's just to have every vehicle have it equipped. The officers receive the in-house training, and then when they go through annual in-service training through CPR, they get it again. In the Municipal Police Training Committee, which oversees all the state training programs, they require Narcan training for everybody, whether the department has it equipped or issues it, or if they don't. And I found that to be interesting, and it makes perfect sense, is the reason they do is a lot of addicts have it prescribed. So officers who don't necessarily have access to it might show up at an overdose and have it there. And if they haven't been educated in how to administer it, it would be a useless tool and it would save their life. So across the state, police officers get trained in this this year, which is extremely helpful because I've never seen it, the way to administer it, and through the in-house training and then through in-service, every officer will be educated in the importance of recognizing what an overdose is, what it looks like, looking for signs of it in the surrounding, in the environment, and then how to administer the Narcan. And I guess in summary for me is our traditional methods of combating this, whether, maybe 20 years ago, if we identified a dealer or somebody distributing, it would solve the problem temporarily. But this is so prevalent that somebody else just fills that void. And the approach that traditional law enforcement has, we're still going to continue to work tirelessly on that, but there needs to be a bigger, I guess, approach to handling this epidemic, which is there's so many other partner agencies that are incredibly putting a lot of effort into this statewide in educating law enforcement, but also, more importantly, I think, is the public, so that we can recognize it and try and do something to prevent another overdose, but also to better educate ourselves so that we can get the help for people that really need it. So in conclusion, I just really want to recognize DA Ryan for her hard work and the benefit that Maynard residents receive from everything that the DA's office puts forward, because she's instrumental in a lot of programs that we are involved with, and an extremely great resource for everybody in town here. And I'll be happy to answer questions at the end. Thanks.
Thank you, Chief. And we're very lucky to have you in Maynard as well, and the work that you do. I would now like to introduce Marcy Julian, the Regional Manager at Learn to Cope. She recently appointed Western Massachusetts Manager for Learn to Cope. Learn to Cope is a nonprofit peer-led support network established in 2004. And ladies and gentlemen, Marcy Julian.
Sure. First, I'd like to thank you, Representative Hogan, for putting this event on this evening. I think every opportunity that we get in every community in the Commonwealth of Massachusetts to have this conversation is going to be key to a solution. As Representative Hogan said, I work for Learn to Cope, but I only work for Learn to Cope because addiction struck my family. And I left a long career as an assistant district attorney to take this job because I was really faced with a very life-changing experience. And, did a lot of soul searching about how I wanted to spend my remaining working years. And as much as I loved my career in the DA's office, I've never looked back. And it started for me about 11 years ago. I think it's really important for people like me and other families to share our story because there's so much stigma that surrounds addiction. And there is not the same type of stigma surrounding other diseases. Addiction is a disease that is no different from any other disease. I have a 29-year-old son who 11 years ago was prescribed Percocet when his wisdom teeth were extracted by an oral surgeon. We didn't have forums like this. We didn't have information about the power of these drugs, the addictive properties of these drugs. In fact, Big Pharma had a brilliant marketing campaign that pretty much misled most of us and misled the medical community into believing it was safe to prescribe large quantities of this for all types of pain. I mean, I don't know about you, but I had my wisdom teeth out a long time ago, and I didn't need something that powerful. I didn't know any better. I trusted the doctor. I trusted the pharmaceutical firm that manufactured the drug. Had I known then what I know now, I would have asked questions. I would have asked for alternatives. I would have said, can we maybe try it for a couple of days? We don't need 2 weeks worth of this drug. And what do I do to get rid of it? So those are all questions that you can all ask now, where you're better informed than I was back 11 years ago. So I recently, just to digress for a moment, I recently heard an addiction medical specialist talk about the disease of addiction as one of exposure. And that hit me like a ton of bricks, because I said, that's what happened to my son. That's what happened to a lot of other members of our families, those of you here tonight who maybe have someone struggling in your family, maybe somebody in recovery. It's a disease of exposure. Without exposure to that drug, maybe things would have been different for my family and for my son. I'll never know that. But I have to believe that when you look at the fact that the Centers for Disease Control tell us today that over 70% of those people who use heroin or are addicted to heroin first started with prescription pain medication, I have to believe that the power of that drug was, these drugs were understated, and we have this crisis because of that. There's a direct link. So, well, I know all that now, and it's sad, but it's true, but it still leaves my family and me with an 11-year journey that's been incredibly painful. And so many of the other families that I've met through Learn to Cope have gone through much the same that I have gone through and my son has gone through. As most teenagers do, he made errors in judgment. Most kids do, but the consequences aren't always that serious. In his case, having been exposed to Percocet, and I recognized at the time that he liked it maybe a little bit too much. I was concerned. I took it away. I said, I don't really think you need this anymore. As most kids do, he went to high school parties. And one of his friends' dad was prescribed OxyContin, and for some reason the dad thought it appropriate to share the medication with his son, who in turn shared it with a bunch of my son's friends. You know, if we look back at that age group, there are so many groups of friends who all experimented, made that mistake, and became addicted. We have an entire generation that has been lost to this epidemic. I'm grateful today that the parents of younger kids can hear people like me talk, can have panels like this to learn, to take preventive steps, to do some of the things I said a minute ago, ask questions, challenge that decision, safely dispose of your medications. So life goes on, and the losses have mounted over the years. It's very difficult for families to watch someone they love struggle with this horrible, horrible disease. I won't get into the details, but a lot of you know what we experience, and I don't mean just arrest, incarceration, overdose. Families are victimized by their loved ones, and their loved ones, like my son and your daughter and your husband and your wife or your grandparents, whoever, That's not the person we love when they're in active addiction. That's somebody who's in the throes of active addiction, whose behavior is driven by a power that I don't think most of us can even begin to understand. So, but it still has an enormous impact on the family, on the parents, on the brothers. I have 2 other sons. I'm sure that they would tell you what their experience has been. As parents, we think, we have a sick kid, we're going to take them to the doctor, we're going to get answers, we're going to fix this. Well, that's not the case when it comes to addiction. Not at all. And 11 years ago, we really had no place to turn. Our medical providers didn't have any information. We all know that doctors have very little training in medical school when it comes to addiction. That's one of the many wonderful changes that are happening now. But nobody could really help us. So, we kind of fumbled along through the years and struggled alone and experienced much the same as other families. We were in constant crisis. All of our energy was focused on one child. Needlessly, we felt a lot of guilt. We felt a lot of shame because we didn't understand addiction. We bought into the stigma that still exists today, I think, as much as I hate to admit that. At times we were angry. We were certainly afraid. We know how dangerous this disease is. We know how many we've lost. We know how many close calls we've had. And we feel very much alone because it's not something you can go over to your neighbor's house and sit down and have a cup of coffee and pour your heart out about. I think that, and I'm grateful that none of my kids have ever had cancer or any of those diseases, but people bring you dinner to your house when you have somebody sick with another disease. My experience, and I think a lot of other families would tell you their experience is they were shunned, they were judged. There must be something wrong with that family. But as you heard tonight, it's an equal opportunity disease. It doesn't pay any attention to your zip code, what level of education, how much money you make, where you live. It strikes suburbs, it strikes the rural areas, and it strikes inner cities. It's everywhere. So I think that reinforces the fact that we now know that addiction is a disease, and I believe a disease of exposure, as I've shared with you. And it's a disease that is treatable, and it is a disease that responds to treatment, I think, in a lot of cases. But what about the families? So, as I said, I kind of fumbled along for a number of years until I found Learn to Cope. And my husband and I live in the Springfield area, and every Thursday night, the closest meeting to us was in Worcester. So it was that important to us. We drove to Worcester every Thursday night, and we met this wonderful group of people who looked just like us, who understood us, accepted us. So Learn to Cope is a peer-led support organization for people like us, the families who are affected by addiction, where we can share with each other our wisdom, our courage, our knowledge, our experience in a non-judgmental way. So, and I heard one of the panelists talk about all the other support organizations. I don't mean to imply that Learn to Cope is the single solution for everybody. We always encourage you to try anything, faith-based organizations, Al-Anon, Nar-Anon, therapy, whatever works for you. But we are another resource, and I left some information out in the lobby. I saw a lot of people coming in with the flyers for Learn to Cope that have the meeting locations listed in them. And I also left a flyer that's kind of a synopsis of a PowerPoint presentation that we give that's been approved by the Department of Public Health. It's called Connect the Dots. And it's meant for families to connect the dots of opioid abuse. It's the signs, the symptoms, the changes in behavior, and the paraphernalia I heard mentioned, and I'm one of those parents who was wondering where the heck were the spoons going and why were they all bent. I was yelling at my kids about, please stop scooping ice cream with the spoons, you're bending them all. I've learned a lot over the years, and much of it is due in large part because I became involved in Learn to Cope. So it's a place where you can get support. It's a place where you can be educated to learn about the disease of addiction, to learn about how we are best able to help our loved ones. The chief of police mentioned families who enable their loved ones because they want to keep the disease in the house. They want to keep the secret. So they're afraid for people to find out. So they let their loved ones live at home. They give them money. They give them food. All the things that we ordinarily do for families. But we have to learn about how it's, things that are pretty counterintuitive to being a parent. Asking your kids to leave home if they can't live at home without using. All kinds of things that we have to do. Section 35, watching your child, calling the police and watching your child go off in handcuffs. All things that are pretty tough for parents to do, but are necessary to do to keep them alive long enough for them to find recovery. So we learn a lot. We have a lot of information that we share with folks about treatment options, the different kinds of treatments. We engage in advocacy. I happen to, as you know, I already mentioned, I happen to have a pet peeve about pharma and about stigma. Probably just in the past month, I've met with my U.S. congressman. A number of us have traveled to Boston. We've testified in front of the governor's working group, all kinds of things like that. So we're vocal advocates. We're outspoken. We're the faces, too, of addiction. We're the ones who are going to affect policy change. We're the ones who have gotten the legislators to listen to us, the governor to listen to us, the attorney general to listen to us about what the needs are. We're the people on the front lines. We're the people who have a front row seat to what's going on. We know what the obstacles are. We know what needs to change. We've had the experiences with the insurance companies. We know that parity is a myth, that there is not treatment on demand for mental health and for substance use disorder. So we're very outspoken advocates, and personally I find that very empowering to be a part of the solution. So it's kind of like taking what life has handed me, a bunch of lemons, and I'm trying to turn it into lemonade. And most importantly, we get hope, because we so desperately need to have hope that the person we love is going to find recovery. And we hear from people in recovery speak all the time at our meetings. And that really affirms the possibility for all of us. And on a more practical level, we're also a pilot program through the Department of Public Health for the distribution of Narcan and overdose education. So at each weekly meeting in the 24, 25 locations in Massachusetts that we now have, we have trained folks who can enroll you in Narcan. It's the nasal formulation. It's pretty easy to use. You heard a lot about it from the other speakers. You just put the medicine in, squirt it, and you deliver it nasally, and it works probably within 3 to 5 minutes. We give you 2 doses. Come back, we give you more. If you lose it, if it expires, if you give it away, for any of those reasons. We just want to make sure that you have Narcan. Since Learn to Cope joined the pilot in December of 2011, over 60 families have saved a loved one's life. I think that's huge. Those are 60 people who got to get up the next day and start over. So that's just a little bit about Learn to Cope. I wish I had more time to talk to you about it, but I want to leave you with a call to action. My husband and I were in Washington about a month ago for the Fed Up Rally in the Unite to Face Addiction, and we were part of a group of 10 parents who got to sit down with Michael Botticelli, who is the director of the White House Office on National Drug Control Policy. And he told us in all sincerity that we are the people who are going to force change in policy, and that by telling our stories, if we stand up and we can do that, then we're going to have the greatest influence. So anybody who's traveling this journey alongside me, I invite you to do that and become an agent for change. So thank you, and if you have any questions about Learn to Cope, I'd be happy to answer them.
Thank you so much, Marcy. We're going to be fighting the clock a little bit around 8. I know that the judge needs to leave, but we're willing to stay, and I know there'll be a number of people willing to stay as we move towards 8 o'clock. I have our final panelist, who is Richard Elbig, Director of Emergency Services and ICU at Neshoba Valley Medical Center. He's been a nurse for 36 years. The majority of his career has been in emergency and critical care nursing. Just completed serving 21 years as a firefighter, EMT, and infection control officer with the West Boylston Fire Department. Welcome, Richard, this evening. Thank you.
Thank you for having me here tonight. I'm going to look at this at a different, I'm going to try to get through this really quick. I come with a different perspective because I had to take care of these people in the field and in the emergency department. And as I was driving in here tonight from Neshoba, I thought back 30 years ago is when I first went into the emergency department. And I remember, like it was yesterday, the night that a car pulled into the ambulance bay, all we saw were headlights, somebody blew a horn, and everybody started to run. I was a new kid on the block. I had no idea what was going on. I thought the ice cream truck was here. And we went out into the ambulance bay, and sure enough, there was someone out there who had overdosed on heroin. That was 30 years ago. Little did I know that 30 years later, I'd be standing here talking about the same thing that we talked about 30 years ago. So I think one of my questions is, where the heck have we been for 30 years? We knew this was going on, and when it finally exploded, it's almost like it's too late. If you look at some of the data out there, I hope I don't foul this up. Okay, so this just gives you a definition of what an opiate is. Morphine, codeine, heroin, oxycodone, and now, of course, we have fentanyl you can make it in your house. And this is the stuff that's causing a lot of problems because they're taking the fentanyl, they're cutting it into the heroin, and people don't know what's in it. They buy it, and they shoot it, and you get what you get. So 1/3 of all injury deaths among Massachusetts residents are poisonings, and among those poisonings, 69% are unintentional opioid overdoses. In 2012, 688 unintentional opioid-related deaths, 10.1 per 1,000 residents, the highest ever recorded rate in Massachusetts, and it's climbed since then. The preliminary data shows that even more deaths for 2013, and we'll talk about that after. And one of the things that bothers me the most, 1,300 babies in Massachusetts were born with narcotics in their systems that year, more than triple the national average. You have to see these kids to understand how horrible this is. You get a brand new infant, just came into the world, and they're addicted to this, to heroin, and watching them go through withdrawal is just, it'll rip your heart out. And that's one of the things that we don't think about. There's a lot of collateral damage that comes along with this stuff. These are opiate-related deaths, unintentional. They were undetermined up till 2014. 1,256, and that's just a guess because the final numbers aren't in yet. The rate of opioid deaths, 2000, look at this, it just climbed. We knew there was a problem. It's always been there. And then for some reason, after 2012, it just started to fly up. And now we're kind of we're playing catch up. And if you look at this, and there's another slide, Middlesex County has the highest death rate in 2014, the highest number of deaths in the state of Massachusetts. I was amazed. I had no idea. 212 deaths in 2014. And I didn't understand it. There were more deaths in this county than there are in the county of Massachusetts and in the county of Worcester. So I didn't quite understand how that was playing out. The spike in related deaths can be viewed another way. In 2012, the state saw 10.1 opioid deaths per 100,000 residents. By the next year, the rate jumped to 14.5 deaths per 1,000. The DPH data brief broke down deaths by county, and in 2014, Middlesex County had the most unintentional opioid overdose deaths. It was estimated at that time as 212, followed by Essex at 146, Bristol at 117, and Worcester County with 113. State police said that in 2000, there's 217 suspected heroin overdoses in Massachusetts through the first 3 months of 2015, though that estimate doesn't include Boston, Worcester, and Springfield. So if you add those in, you can imagine how bad it is. So these are all the poisoning deaths, and just poisoning, not narcotics. And those numbers are coming down. We're doing pretty well over the last couple of years, but the opioid deaths just keep on climbing. Motor vehicle accidents. We're doing great with motor vehicle safety. Over the last 10 years, you can see how the number of motor vehicle deaths has declined, and the number of deaths due to opioid use is just climbing. 150 deaths in January of 2015. And from 2005 to 2014, 6,878 people have died. Now, one of the things that, and I think the district attorney talked about prescriptions. I'm probably going to get some heat for this, but the medical field has to take responsibility from this, because we did it. And not only did we did it, now we need to fix it. You can say anything you want, but when you look at the numbers, and these came from the state. These are recent numbers. I just want you to listen to this. The number of individuals who received Class II opioid prescriptions in 2013 in Middlesex County alone, 142,350. What that breaks down to is, and I couldn't believe this, but it kind of figures, 26,779,541 individual capsules, tablets, or whatever prescribed to patients just in Middlesex County. What are we doing? You know, I've seen cases where, you know, somebody goes in and has they have a arthroscopy of their knee, which is, you know, it's a little bit painful. And they give you Percodan for that. Back in the day, you get Tylenol, you get Motrin, and you were good with it. We've come so far that we have to make everybody pain-free. What we're doing at Neshoba now is when a patient goes into the OR, the nurse in the PACU talks to the patient and says, when your surgery's over, you're going to have pain. We're going to give you medication to take the edge off, but you're never going to be pain-free. And we've missed that. We've done so much to try to make the world pain-free that we've caused a nightmare. And it's going to take us a long time to fix this. I was just absolutely amazed at the number of prescriptions. You know how many pills that is? The drug companies are probably clapping. So we need to get a handle on it, and we are. The emergency room physicians have sat down and said, look, we're going to start limiting what we do. One of the things the state has done, we can go online when a patient comes in, and before we write a prescription for a narcotic, we go online to see if that patient's had prescriptions in the past and where are they coming from. We had somebody the other day that came in, had been to 30 different pharmacies. Same complaint, sorry. And they get angry, and then we get a letter that goes to the president that says, you guys are miserable, awful people, we have pain, and you haven't given us any pain medication. We're taking a hard line on that. The smallest sufferers, and I said, this keeps me awake at night. A baby is born every hour in the United States with symptoms of opioid withdrawal. When you hear this kid's cry, it doesn't sound like a kid crying, it sounds like a wounded animal in the woods. It's just absolutely horrendous, and it takes, you know, sometimes up to 16 days to get these kids clean, and sometimes it takes longer. They may end up in the NICU. And this is collateral damage. We think about the person who injects heroin or whatever, and they have a respiratory arrest, and we give them Narcan. We think about all that stuff. But nobody thinks about these kids. It's one of those things that's kind of buried under the rug. Nobody wants to talk about it, but it's out there. So an estimated 13,500 babies are born with withdrawal symptoms each year in the United States. Researchers found the number of pregnant women using opioids increased 5 times from 2000 to 2009, while the number of infants with withdrawal symptoms tripled. Again, what are we doing? Infants born addicted jumped in 4 years. There were 1,300 Massachusetts babies, or 17.5 per 1,000 hospital births, born with narcotics in their system in 2013. That's more than triple the national average. I can't understand. I don't know why. I wish I did, but I don't know why. Reasons for the high rates of opiate abuse in New England range from overprescribing by physicians and drug dealers in major urban areas. They recognized untapped markets due to a lack of detox beds and treatment programs that all these folks are trying to fix. We're all trying to find more places in a better way. How can we help these people? The unfortunate thing is they need to want the help. They need to want to get off this stuff. We can set them on the road, but somebody needs to pick up the ball after they leave us and carry them the rest of the way. And the oxycodone is pretty much they're trying not to use it anymore, not to prescribe it. So that abuse has dropped, and the price of heroin has gone through the floor. So some of the stuff that MDPH has some objectives that they came out with when Governor Baker put his task force together. And they've now allocated a significant amount of money to try to deal with this. I just wish that some of that money had been allocated 15 years ago, so we wouldn't be here talking about this. Because this affects families. Families are torn to pieces, and really, I've lost track of the number of times I've had to sit with a family, sit with a mother and father, and explain to them that we did everything we could, but I'm sorry that your son or daughter died. And I walk out and I say to myself, what a waste. What a waste. Where did we drop the ball, and what are we missing? Because we missed something. So prevent and reduce the incident of opioid abuse and overdoses. Again, it's an education piece, it's a detox issue, and it's easier said than done. Improve the management of overdoses. Well, we're doing that with the Narcan. You saw the nasal Narcan. The latest thing that's out there now is something that's really simple that they can carry. You open it up, talks to you, tells you exactly what to do and how to use it. You put it back in the box, and you take it to the pharmacy, and you get a new one. So we're doing some things to keep people alive, but we need to take that further step and find out why they're doing what they're doing so they don't need this stuff anymore. Reduce the misuse of prescription opioids, which leads to overdoses. We got to get the docs on board. There's a physician group in the state that's given some pushback because they feel that the legislature is trying to tell them how to practice medicine. Well, you know what? You're probably right, and it probably should have happened before. Because, again, it's our problem, we did it, we got to fix it. Increases in the number of people who access treatment, and I think that's another education piece. We need to get these people educated. There's a ton of stuff out there. If you have a family member that has a problem, all you have to do is go to the DPH website. There is a ton of information. They'll tell you where to go, who to call, and they'll get you the help you need, but you got to go out and find it. And it's not something you can cover up. I had a brother-in-law that was hooked on cocaine, destroyed his marriage, destroyed his life. Finally, after 10 years, got his act together. But he lost everything by then. So the 4-part strategy is to promote safe opioid prescribing, I'm hoping that the legislature holds the physicians' feet to the fire and makes sure that this stuff gets done. Provide help for someone who becomes addicted to prevent sickness, injury, and death. If you know somebody who's addicted, make the call the hotline, and get them the help they need. Treat people's addiction to alcohol and other drugs. You know, we've had an alcohol problem for many, many years. We're doing maybe a little bit better, and provide recovery support for the individuals and their families. You can do everything you can for the patient, but you gotta remember that there's a family involved, and you have to include them, because it's not gonna work unless the family's on board, and they're the ones that are gonna help move that down the road and get them to what they need. So all the information came from Massachusetts Department of Public Health and the Massachusetts Medical Society. Again, this is a tough issue. I have to thank the folks in the legislature and, you know, my colleagues in law enforcement, my brothers in the fire service, and my fellow nurses in emergency nursing. We got a long road to hoe, but if we all work together, I think at least we'll make a dent. So thank you. Have a good night.
Thank you, Richard. Right now, what we could do, I know we've been talking at you for a while, but if anyone has any questions for any of the panelists here, we'll be happy to take them right now. If anybody wanted to come down to the mic right here.
Good evening. First, I want to say thank you very, very, very much to, Representative Hogan and all of you, because it is absolutely critical that we do continue to have this conversation. Where I'm struggling is I appreciate all of what you've talked about, all the different programs, the justice, the law, the programs. But to me, it's like putting a Band-Aid on a major bleed. It's absolutely critical, it's absolutely important, but it's not enough. And while the education is great, because we have to keep more from coming into the system, I struggle with what do we do with the poor folks who are already in the system. Those folks who have struggled. Maybe they went to the police department a few months ago and said, I need help. And they got help. 2 weeks is not enough. We all know that. So what happens after the 2 weeks? Okay, insurance pays for 2 weeks. They're in a 2-week program, but that's not enough. Where in Massachusetts are the step-down programs? Where are the sober houses? Where are all the other policies and procedures and programs that are needed to make sure somebody who wants help gets the help and stays on the straight and narrow? So my appeal and my plea to all of you, in particular in the legislature, is push the funding. We need the funding to come away from some of these other wonderful, lovely programs and put them where they're going to save and help our kids, our parents, our brothers, our sisters. Help us with the programs that we need, funded by the state, to make sure the people who want help get the help initially and from there forward.
Did you have a question?
The question is, what's next? I mean, where is that funding coming from? Where are those programs? What does somebody who wants help, where do they go?
One thing that I can tell you on the part of the legislature, as Rep. Malia, I'm Rep. Malia from, I forgot to say before that I serve a district in the city of Boston. We're at the point where we're learning where some of the holes in the system are. We're getting to a point where we've been able to implement new legislation. We're trying to put some money into the places where the beds that we've talked about tonight, the services that we're talking about. But the need is, as you said, is much, much greater than we've had the resources for up till now. So I think what's happening is that those of us in the legislature and then all our related agencies, whether it's law enforcement, in the courts, our providers out in the community that run detox programs and residential programs, those of us who are advocates, we're all trying to work together to bring those resources in. Fairly recently in Massachusetts, we instituted Chapter 258, which started again the 1st of October, that forces the insurers to pay for at least the first 2 weeks. That's not enough. It's the first step. We need community folks. We need people to advocate, call the governor, call our offices, and basically lobby for that funding to come, for us to put the funding into the programs that are working. And again, all I can say is thank you, because this conversation is one of the things that's helping to move us in that direction in a much more positive way. 10 years ago, 15 years ago, some of us knew that there was a serious problem. We didn't have words to describe it. We didn't know how to allocate funding for it. We're getting better, but there's a long road ahead of us, and that's one of the things that we've heard from the members of the panel tonight. And we have to do it together, so thank you.
Can I chime in? Sure. Thank you. I heard you mention, where are the programs, where are the sober houses, and that you raise a really good point. Many of our loved ones have to turn to sober houses, which we know are different from the halfway house and recovery home model, which is publicly funded through the Bureau of Substance Abuse Services, and they're regulated and they're supervised and they're held to certain standards. But I understand that some of the pending legislation is looking at regulating the sober houses because there's such a vast variety in quality, and some of them are literally flop houses and some of them are very good programs, but it's very hard for the consumer or the family to get the correct information. So until now, it's been my experience that that's the type of information that the families share. And I didn't mention, we do have a family discussion board on our website where you can get lots of information about particular programs if you happen to be looking for that.
And just to add into that, we have a new piece of legislation that we're waiting for the governor to implement, and we've been told by the Department of Public Health that will be implemented this winter, which will provide for certification programs for sober houses, so that people are trained and are educated and are following basic standards. That will be, we've been told as recently as yesterday, will be in place by October. And, again, our Department of Public Health will have that information, and hopefully that will help to unify and really improve the quality of some of the services we're getting.
Thanks, Liz. Is there a gentleman here?
This is the other side of the story. What consideration are you giving for those patients for whom opioid pain relievers are a medical necessity?
That will be part of the bill that we put together as we move in this legislative session. I know that there will be an important piece on that in the legislation to protect those folks that are in need. So it is acknowledged, and it will be part of the legislation. There will be language in there that will reflect exactly what you're talking about. Yes, please.
Thank you, Kate. I have a few things. My name's Anne Marie. I'm from Hudson. My daughter was 13 years in the medical system with infectious disease, broken femurs, legs, wound vacs. That was our life for 14 years. She's 26 now and addicted like the rest of us in terms of talking about families. But my daughter has the same issue, regardless of how we got there, as the heroin people that have accelerated to that. She hasn't gotten in trouble with the law, so you wouldn't know her. I belong to Learn to Cope, and it's given me a lot of the strength that I've needed to be able to know, first of all, that I'm not crazy. But I have a couple questions. I have some questions for you that I'm also on the Patient and Family Advisory Committee for UMass, so I might know more than most in terms of how the medicine part works too, sir. So thank you so much for bringing up a lot of the things that we've said right along. The medical community does own a piece of it, and right now they don't think they do. The pharmacies are making, not the pharmacy, the pharmaceutical companies are making a lot of money off of our children. I went to a funeral Friday in Marlboro for one of my daughter's classmates. My husband went last night in Fitchburg to another 23-year-old child. Same thing. And like you said about the Learn to Cope, when I went, I belong to Framingham. And the first time I went was last October, and I was given the flyer by one of my daughter's therapists. And I went into a room not knowing anyone, and I looked around, and I said, thought to myself, oh my gosh, they all look just like me. No, not right now, but, you know, when I look fine. But they, you know, they all have full-time jobs. They all, you know, moms and grandmothers and people are working full-time or part-time and trying to make it work and taking money out of our 401ks to get our kids programs, sending them across the United States to get a bed because there isn't a bed right now. I've done it all right? And my daughter now, God bless Kate Hogan and her staff, because that's who I called when I, in the medical community, have exhausted everything else I know. I also am the director of our local food pantry, so I see it all the time everywhere. So when I felt like I was at wit's end, I thought, what are the other people doing? No wonder they're going crazy. So Kate's staff helped me look into things for my daughter, to find her a bed, to find things that were available. In the meantime, when my daughter came back from her trip out west, they had overprescribed medicine to her. 2 days later, she seized on the floor of my kitchen floor and now can't drive for 6 months. And because of that, they didn't want to take her into this brand new program. She was going to be the first patient in there, and it would have been an ideal situation. But so even when you talk about these programs, just because they're a program and they're online, there's no legitimacy to any of them. And I'm here to tell you that my daughter was in ICU for 4 days in Marlboro, not knowing what had happened, because she hadn't taken anything since she'd been home. So it's coming from a lot of different places that aren't, you know, we're just trying to grasp for things. But anyway, one of the things that I have come into contact with through Learn to Cope that I wanted to share with everyone is in Dudley District Court, there is a judge there that's been working many, many years with the community because he lives in that community in Worcester, and he has been asked to replicate what he does and how he handles his court, which is referred to as his drug court. My question is, no money has been given to him to run this court, but he has assigned beds for him long before the Gloucester Police Department did his thing. This gentleman has been doing this thing for the last couple of years, and he's been asked to emulate it in the Commonwealth of Massachusetts with not an extra dime. This gentleman, his name is Tim Bilbao, if I say his name right. And he's an attorney, he's a judge now, and but he's actively involved with the community. And one of the things that he does when he spoke to us was, first of all, he doesn't call them, he calls them his clients. So his terminology with these people, it's a big deal, it's a mental health issue. And one of the things that I appreciate you guys for being here for is, whether we're a volunteer, I'm a volunteer, but you can't pay someone to care. You can pay them to do a job, but you can't pay them to care. He cares. He's been doing this stuff all along. And when we talk about money, it isn't just about money. It's changing the way that people think about how do we best take care of these kids. And, you know, anyway, he's doing it very well. Dudley District Court, he's phenomenal. If you look him up, he does a lot of talks and he talked at Learn to Cope in Framingham and Worcester, and but he's wonderful. Anyway, so look him up, he's wonderful.
Can I say something? His name's Tim Bebo. He's a prosecutor for Worcester County for 25 years or so, and he's, you know, that when you deal with this stuff on a daily, it does change you, and he does care, because you see all the tragedies and the bad stories and the, you know, and the struggles people go through. He's an outstanding person that I've dealt with, you know, in my experience, but he's doing a great job out there, too.
Then he said, how do you change the way people think?
Yeah.
And it's a mental health thing. And it's taking the stigma away in these kids that need help. And what's really, I just remember when he was talking to us in the spring, he had one of his clients that would walk almost 4 miles to get to its court, to be there on time for that weekly meeting that you talked about. And he has the respect and trust of those people. And they come even after they're done with their graduation that you mentioned. Just phenomenal. And that's here in Massachusetts. So we have some wonderful people. The other thing I wanted to ask has to do with the police. I live in Hudson. During our forum, we asked why our police officers didn't carry Narcan. I do. It's a part of Learn to Cope. It's what we do. And they were told that they didn't feel comfortable, that it was up to the chief. And we all just looked at one another saying, you gotta be kidding. What you gotta understand with Narcan too is that I learned at Learn to Cope, and I learned through talking to people at AdCare and stuff, which is one of the treatment centers, is Narcan only buys them so much time. And sometimes they need to Narcan them multiple times in the ambulance to keep them, all they wanna do is get them to the hospital, because that's what Narcan does. And it has to be done quickly, and sometimes it needs to be done multiple times. But for something that critical, why it isn't enforced? This is like crazy.
You can answer, obviously.
Yeah, I mean, I can't speak for Hudson Police Department. You know, unfortunately, one of the biggest problems with it is the expense, which is why DA Ryan provided it to every police agency in Middlesex that wanted it. We have an agreement through Emerson Hospital that basically like our ambulance service, so that if we have it basically prescribed to us through the hospital, so if we use it, we can get it replenished just by going there. So there's different models out there.
So how do we get it in every single town in Massachusetts?
I think it's like everything, change takes some time. And I think it's also, people have to have a comfort level with doing it. That's why we've been providing the training, we're educating people about it.
Yeah.
I think that everybody can imagine if you were suddenly said, we're gonna give you this and you're gonna be administrative. People think, I don't wanna be doing that, I'm afraid, I don't know how to do that. And we're working on that. That has changed, as the chief knows, that's changed dramatically over the last year, the last 6 months. So we are moving forward with that piece.
Okay, that's great.
Thank you,
And the
Emery.
Attorney
One more
General-
question.
The Attorney General has also, Attorney General Healy has worked out an agreement with the company, the pharmaceutical company that makes Narcan, to get them to pay $325,000 into a trust fund that would make Narcan more affordable to cities and towns across the state. So there's some effort. That's not going to cover everything, but there are some efforts.
And last but not least, thank you so much. Last but not least, I just wanted to talk about jobs. I work in a banking setting during the day, and I can tell you that there's people and families that struggle that I work with that don't want to share their life experiences with other people that could save other lives because they're afraid of losing their jobs. How can somebody help us with that?
Well, again,
To protect
that's a place where we need to be more aware that recovery includes getting your life back, getting jobs back. It also is a general lessening of the stigma, whether it's in your neighborhood, whether it's at your job. That's what's important. You know, that's what drives much of the work that we do. You make an important point tonight and put a human face on this. I'm a prosecutor, but before that, I'm a mother, and I would move heaven and earth to save my child. And that's what so many people are struggling with. And that is what, you know, it's the same is true for all of us here. That's what informs our work in going forward in this crisis.
Thank you. Thank you, Anne Marie.
Thank you, thank you.
I just, Tara Mariolis, I'm from Bolton, actually, and I'm a nurse, and these are my nursing students. They've graciously agreed to come with me because they're so invested in this topic. But I guess, just to be very quick about it, I've talked to nurses about this before, and I've seen physicians overprescribe opiates. And I'm curious, there isn't a physician here tonight. I mean, it's great to have a nurse here, but I think that they are resistant to being told that the way they're practicing is problematic. And I just wondered if you had any ideas on how to have a dialogue about it with physicians.
You know, I think it's a turf issue. It's always been a turf issue. I'm lucky enough to work with a group of physicians who actually really do collaborate with the nursing staff. And I think it's because Neshoba's a small emergency department, and we have to depend on each other. I managed the trauma center in Life for 3 years, and it was much the same there, but in the small town community emergency department, you don't have the resources. You got to either do it or you're not going to do it. And we're lucky enough that works. My chief, my medical chief, is really taken he's taken this to heart. And we spoke today about, you know, how are we going to deal with this? And I'll tell you, we're getting a lot of heat from the patients. The state, if I'm right, is going to there's going to be a maximum that you can prescribe, and I think that's what the physician group is talking about. Well, you know what? You can't have it both ways. If you have somebody who has terminal cancer, you have to individualize it. Yeah, absolutely. We're going to take care of them. But if you're coming to me because you have pain in your knee or you sprained your ankle, we need to take a hard line on that and give them the least most effective drug. Not oxycodone, not Percocet, not Percodan. You just can't do it, and that's why we got in this mess.
Thank you. Thank you for the question.
Can I just add that there's a lot of scope of pain trainings taking place for prescribers now, too, which I attended one, and I thought it was very provocative, very provocative.
Thank you. Maura?
Hi, I'm Maura Flynn. I live in Maynard, and I want to thank all of you. This has been terrific, really, lots of great information. I had a couple of questions regarding some of the information we got. One of the questions that I had was the mandate for the 2-week inpatient for the insurance to pay for it. I wanted to know if that extends to Medicare and Medicaid.
We're implementing, as we speak, we're implementing the program throughout the state. There are some cases where insurers who are out of state, in other words, some people who work for an employer who has an out-of-state insurance company, where there isn't compliance. But again, this has been up and running for about a month, and as far as we know, this is accessible. It should be accessible, and again, all your legislators should be able to direct you to some of that information, and the Department of Public Health information line, which would help you with that. But again, we're hoping, you know, we haven't heard, we're getting a little bit of feedback from places where there have been some problems, but I think it's a major change for the state that we at least can get people through the detox part.
Will they pay for follow-up care in that mandate?
Each insurance policy is different, and part of the work that we have to do is to convince the insurers and then work through the state legislature to fund the programs and the beds and the treatment options that are out there. So it's a work in progress.
Okay, thank you. I have
one more question.
I'm not going to pontificate, okay? I wanted to know in Maynard, is there a take-back program for controlled drugs?
Yes.
And do the residents know about it? Because I have not seen one.
We don't have a program. Actually, the DA's office provided a container that's in the lobby of the police station.
Okay.
So it's 24/7. You can just come in and
Okay.
drop
Do
it
our
off.
residents know about it? I think we need to put out some more information in the
Yeah,
town.
we certainly can again. I mean, it's posted on the website. It's been pretty highly advertised
We've pushed
over
it
the
out
years.
pretty hard, yeah.
But
I haven't
it's something
seen-
we can do again,
I
certainly.
happen to know because I'm on the MRC, but I don't think you're a normal person who has those bottles of drugs in the back of their medicine cabinet.
You know, maybe
about it.
going through the COA and all sorts of different organizations within the town, again, the back and forth dialogue that we're having, that might be a really great thing to get
Yeah.
out and make sure that everybody
Yeah,
understands.
because it's good to have it. I
about.
know at one time you could only come at certain times of the year.
Right.
Thank you very much.
Thank
We
you, Maura.
actually have a Sharps container too on the front stairs, so you can drop those off too.
Hi, my name is Jennifer. I live in Maynard, and my family has been touched by this crisis. My husband lost his brother. There was a baby born addicted. He's going to be 3 soon. He lives in Maynard. One of the things that I think is a really big part of, or one of the elements that is a piece of this I didn't hear a lot about tonight, and it's just, maybe it wasn't part of what you were presenting, but I'm wondering what we are doing in a systemic way to ensure that our youth, adolescents, and teens have good mental health. I think that that is a huge part of why kids can become addicted. I know I have a 15-year-old daughter. She's a freshman in high school, and she was in the bathroom crying the other day about the quizzes that she had. And she's a freshman. She's starting to hear about, oh, grades count now. You know, you've got to do this, you've got to do that. You've got to know what your career is going to be when you're 15 years old. You know, people are graduating from college, they don't have jobs. So there are a lot of pressures on our youth and our teenagers. And I think that good mental health is another prong to this puzzle that, you know, should be addressed in a systemic way. And I'm just wondering if there is, and I just haven't heard about it yet.
Within our office, we run a nonprofit in the office called the Middlesex Partnerships for Youth. You might have heard it referred to in the schools as MPY. Every one of our school districts across the county belongs. Part of belonging is you get a minimum of 5 free in-service trainings. Probably our highest subscribed trainings are our mental health trainings. So we bring together some great panels of folks to talk about, you know, the academic stress piece, the suicide prevention. We've had towns across the county that have been dramatically touched by suicide in the high school. So that's a very, and they get those 5 for free. They can use them however they want, and then we'll also do over and above really whatever a community wants. So that is a great resource. We've been operating it for about 20 years, so we've got a deep well of mental health professionals who help us with that. I agree with you, that's something we are out all the time. We also run, and will be running December 1st and December 3rd. I sponsor an Empowering Girls program, which is aimed one day at middle school girls, one day at high school girls. We really look to those pieces. Our program this year, which your kids will be getting flyers in school about, is called Curating Your Life. We're going to use the museum mode of curating to help kids really get to a good place in their own mental health, taking some responsibility for those choices and things that they're doing, and really eliminate some of that stress. I mean, I'm also the parent of a couple of adolescent kids. I know that stress, particularly in high-achieving towns. It is ridiculous. Every time I send my troopers in the local offices out to respond to the stress of a teenager, and then we find out it's been triggered by some school performance, that is an indictment of us as parents. So that's something we take very seriously. We provide a great deal of resources around those topics.
Thank you very much. I disagree it's an indictment of parents, however. I don't put any pressure on my daughter. It's coming from school. And I just happen to be a parent who addresses mental health, and so my kids are going to get what they need. But I think that it's an overall problem in our country overall and in our state when we don't have enough money to fund the adjustment counselors in our schools. And my daughter has been screwed by every guidance counselor that we have on multiple different things. And it's just, they're so overworked that they don't have the capability to address students in the moment when things are happening. So should we consider, as part of our funding initiatives, ensuring, not touching on or working on or training teachers, but ensuring good mental health for our youngsters?
Thank you.
Hi, my name is Elise. I'm a nurse. I'm also a resident of Middlesex County. I have 2 family members who have actually overdosed on heroin fairly recently within the last year, and one who's currently incarcerated. He's been in and out of the system about maybe a dozen and a half times. I know that we look back on the data to see what the trends are for what these people are doing and what, you know, where they're hanging out and what works for them and how they're kind of cheating the system. As a nurse, I'm a mandated reporter, but I also want to know if there's any organizations in place that we can report trends that we're seeing. I know that we can report criminal activity, but as somebody who's involved in this, treating it, and also as a family member, I kind of have my finger on the pulse of what I see is going on, and they're getting savvy and they're getting smarter, and by the time I feel like we figure out what they're doing, they already have a way around it. So is there a way that I can report these things or kind of tip these things off that aren't necessarily criminal, but trends that I'm seeing as a healthcare provider, but also as somebody who's being affected by it?
I think we're in a moment when people are collecting a lot of that information. I mean, I think there are lots of, the governor has an opioid task force. I think DPH is very interested in collecting a lot of that information. I think probably our office, the Attorney General's office, everybody's got a group that's kind of looking at these issues, so I think you'd find lots of people to chat with about that.
So would the best thing to do would like to go online and research it and then just send
Depending
emails
on what kind
and
of
then?
thing it is, yeah.
Okay.
If you're finding that people are particularly, as the chief mentioned, they're scamming elder relatives or something, that's something to call the Office of Elder Affairs about and talk to them about it, whatever the nature of that is.
Okay, so like specifically whatever.
And if you want to call my office, we can also help direct you, so.
Okay.
Okay.
I have quite a few ideas. All right, thank you.
Okay, good.
Thank you.
Thank you. Well, thank you all for being here this evening. I am so very grateful to the panelists. I'm so very grateful to the audience members. I'd like to particularly thank the Maynard Public Schools, Maynard High School for hosting this evening, Superintendent Bob Girardi, who's actually here and sat through the entire event. We're very grateful for his support. And I would also especially like to thank WAVM, who is also here taping this evening. They're really extraordinary people and extraordinary kids, and they do great work. So thank you all so much. Maynard Police, Maynard Fire, Town of Maynard, Learn to Cope, all of you are fabulous. Thank you so much for this evening, and I hope that we work together moving forward. Thank you.